Hi, Rebecca. Nice to meet you.
Hi, Henry. Good to meet you too. Can you hear me okay?
Yep.
Perfect.
We'll give everyone till 1:05 and then we can get started.
Sure, no worries. Matt, how are you doing?
I'm fine. How are you doing?
Doing okay. We're like having a huge thunderstorm happening back behind me, so
Oh, nice.
yeah,
I
not
was just sort of doing the usual Charleston summer threat, but not actually accounting to anything.
Nice.
Good afternoon, everyone. Thank you for joining this week again. Today we have Rebecca Starr today, join us from Ernest Children's Center. Thank you again, Rebecca, for presenting to us, and you can start sharing your screen now. I think I lost Rebecca. Rebecca, are you still there? we'll give her a couple of minutes going back.
Yeah, we have a big thunderstorm rolling through Louisville right now.
Yeah, she did mention that, so maybe that's I was giving her a few minutes. Maybe her Wi-Fi shut off for a little bit. Welcome back.
Oh my gosh, we literally lost power and I'm at work, which is crazy.
Oh yeah, so that's what we figured. Yeah, because you said that the thunderstorm was there. So
Yeah, it's intense. So all right, well.
Well, yeah, thank you for presenting. So you can take it away, and thank you again for presenting to all of us.
Yeah, absolutely. No, thank you. Sorry if hopefully we don't lose power again. That would not be good. Let me share my screen. All right, how's that look?
Looks fine.
Perfect. Okay. So like Henry said, my name is Becca Starr. I'm one of the Pimentonians here at University of Louisville at Northern Children's. And so today I wanted to present a couple of ocular cases, some cool ocular cases that we've had recently. So pretty informal lecture. If you have any questions or comments, please just feel free to shout that out. I don't think I can see the chat, so if there's anything in the chat, just someone holler out and I'd be happy to answer it. All right, so we'll get started with the first case. This was a 3-month-old female that came in. She had a history of bacteremia at 3 weeks of life, but has since been doing fine. And she presented with an absent red reflex. Our concern for that. Mom was looking through some photos on her phone and realized over the last few days that her eyes looked funny in some of the pictures. So she went to her pediatrician that day, and the pediatrician referred the patient to us. Otherwise, the patient has been doing fine, no fevers, no vomiting. She's been tolerating PO well. And mom feels like her vision is fine. She feels like she tracks well, and had no real vision complaints. Just looked weird on the picture that mom was taking. So on her exam, her vitals were all normal. She was afebrile and very well appearing, pretty happy 3-month-old. And for her eye exam, she would track for us, but she did have an absent light reflex there on that left eye. So we wheeled in our trusty ultrasound machine, and we used actually a tegaderm over her eye with some holders. So our resident and mom helped kind of hold her head in her arms.
Hey,
we were able to
Becca?
get some pretty good pictures. Yeah.
I don't know if it's intentional. I at least am seeing your full presenter mode with notes and next slides. I don't know if that's how you want it to be or not.
Let me see.
What about everybody else?
Yeah.
Yeah, thanks, Matt. I was going to bring that up too. Sorry.
No. Thank you so much.
I know Keynote, you can see one and we can see the other. I think PowerPoint, you're stuck with.
How is that better? Or no?
This,
How's that?
yeah, that's fine.
Better. Okay, perfect. Thank you. Okay, so here's our ultrasound. So this is the patient's left eye, which was the eye that was affected with an absent reflex. And you can pretty much see here. What do you guys think?
Whatever it is, it shouldn't be there.
Absolutely. So there appears to be some type of mass there in that posterior orbit, and given her clinical scenario, concerning for retinoblastoma. And here, the big thing that you want to look at is also these tiny little calcifications you can see. So these, I don't know if you can see my mouse or not. There's tiny little hyperechoic areas, which are pretty pathognomonic for a retinoblastoma. So other things that you want to look for in this would be, is there extension of that mass into the optic nerve? And we did not see anything like that. So this was her left eye. And then we did her right eye as well, which was, pretty benign, looked well. no issues there. And so here's some stills side by side with that right eye and the left eye. So we were able to measure it in a pretty decent, lesion there. We measured it almost, 1 by 7 centimeter mass. So we were concerned for retinoblastoma. Ophthalmology was consulted, and they were at bedside and did a dilated fundoscopic exam for her. We consulted hem-onc as well. The patient was admitted, got some further imaging with her brain and orbit MRI. And it did confirm on imaging that there was a retinoblastoma there. But luckily for her, there was no optic nerve involvement, which is great. You can kind of see it right there in that posterior lobe. So kind of a cool case in the fact that we were able to make the diagnosis within, a few minutes of the patient being seen by us, or at least, had concern for what the diagnosis was. So I really think ultrasound will play a huge role for this child. Spoiler alert, though, I didn't put this in. Dad had a history of retinoblastoma as a child, and so did his sister. So there's a pretty strong family history. And so the parents had been concerned that that was what was going on too. So they actually did come in, with the concern for, could this be retinoblastoma? So it's always nice when your patients kind of come in telling you what they think is going on. So I wanted to do a lit review to kind of see, what literature is out there for pediatric retinoblastomas. And there's really not a ton as far as the ultrasound literature goes. There's been a few case reports, but this article I found was a few years old, so 2001. It's an ophthalmology journal, which looked at 48 patients with known retinoblastoma. So it's in their retinoblastoma clinic. And they looked at, after radiotherapy or chemotherapy, would ocular ultrasound be important in following these patients up, and could we still see it? And so they did find that the ocular ultrasound was able to detect the retinoblastoma and could also see those calcifications. So would be helpful in monitoring, long-term care, or, if there was further development of the tumor. But ultrasound was not ideal at kind of assessing whether there was optic nerve invasion. So that was really the best paper I could find on that one. Any cases or any concerns or questions on that one? All right, so we'll go to case 2 then. This is a 6-year-old male who's healthy, who came in from an outside hospital with concern for papilledema just of that left eye. So he had had some reading issues in school, and so the parents were concerned that maybe his vision was why he was having these focusing issues. So they took him to the local optometrist, where he was evaluated and found to have this papilledema of the left eye. So he was referred to RER for further management, for brain MRI, further workup as needed. But the kid was overall pretty healthy. He denied any vision changes. He had no eye pain, no headaches, and had been, acting well. So on his exam, vitals were all normal. He was well appearing, and his ocular exam, his pupils were reactive. Extraocular movements were intact, and he did have, some questionable optic disc blurring there on that left eye. Otherwise, cranial nerves were good. So here's his ocular ultrasound. We didn't get videos, unfortunately, but we do have some pretty cool still pictures of his eye. This is the one that had the papilledema that was seen at the optometrist's office. So anyone want to take a stab at what they think this might mean? Or do you see anything that's concerning or different, I guess?
Well, there's a hyperechoic there, like calcification will give you a mass, right? Yeah, that's causing there. So an optic nerve glioma.
Yep. So it's actually, yeah, you're right, a calcification there on that optic nerve, which is pretty classic for what's called an optic nerve drusen. So this was the first time for this patient that I had seen one in patient care. So it's kind of neat to get that diagnosis. And again, ocular ultrasound is really the way that you diagnose it. So yeah, his left eye had this optic nerve drusen there. And then if we measured the optic nerve sheath diameter, it was actually normal for him, which was good. So we consulted ophthalmology and the team. They were at bedside. And they were pretty happy with our ultrasound and took a look at that. And it basically kind of sealed the deal on the diagnosis for this patient. So they did do a dilated endoscopic exam. And they said that the optic nerve was elevated and bumpy with characteristics for this optic nerve drusen, and really had no other pathology on his exam. So they agreed with our diagnosis of optic nerve drusen, and luckily for this kid, he got to go home because it's a benign condition. So he got discharged home from the ER and had follow-up with ophthalmology in a week. So changed this kid's management completely, which is awesome. So here's what an optic nerve drusen looks like on fundoscopic exam. Obviously, this is a pretty beautiful picture. We may not see this as crisp in real life, but you can kind of see that bumpy appearance to that optic disc. It's a pretty benign course. Basically, we just have ophthalmology follow them. There's not really any management that happens. Pretty low prevalence, but can occur, especially if there's family history. It can be unilateral or bilateral. And if you do have any complications or symptoms with it, there's sometimes some peripheral vision, like deficits that you'll see. But a lot of times these kids do completely fine. Any questions on that optic nerve drusen?
I've seen just a couple on POCUS. Never seen it like with the classification. Is that like later onset kind of thing? Just because I've never seen that classification. I know that you get the pseudopapilloma, the way they call it, but never seen the classification.
Yeah, I think it's pretty common from what I can read on it. It's just calcium and protein deposits there on the optic nerve, and I don't think that we know like specifically why it happens. But that's what you see, like you said, on POCUS, which is kind of neat. You have that very, kind of characteristic little, hyperechoic mass there right up that optic nerve. So you can sometimes see some shadowing associated with it too. Right. So case 3 is a similar case of case 2. Or goes along with it. This one was a 15-year-old female who was previously healthy, and she came to us for concern for swollen optic nerves and had also had some headaches for about a month. This girl basically had a vision, normal vision screen at school, and she had failed that, and so had been referred to her local eye doctor. When she was seen at the eye center, she was diagnosed with bilateral papilledema, and so was sent in to the ER for further eval as well. She had no complaints at the time of presentation, had no headache, no fever. She had not been vomiting, and was not altered at all. So for her exam, pretty benign exam again. Vitals were all stable, and for her ocular exam, a little bit of questionable blurring of her optic disc there. Otherwise, no cranial nerve issues at all. So we wrote in our ultrasound with that history of papilledema and a headache. And then this was our video that we got. So you can kind of see similar story to our last patient. You get this very hyperechoic kind of mass-like structure right there, that optic nerve. So we had our concerns for optic nerve drusen again. And I'm going to show you these still. So the still picture is, pretty classic for it too. We've got this nice hyperechoic mass there. And then we measured her optic nerve sheath diameter, which was enlarged at 0.67. So a little bit different story now from our 6-year-old that was totally healthy, had no symptoms. She's had headaches for a month and now her optic nerve sheath is also dilated a little bit. So ophthalmology and neurology were consulted for her. We had a brain MRI, MRV that was obtained in the ER, which was normal. And then the patient was admitted for further consultation and for an LP in the morning. But interestingly, that morning, her LP was completely normal. So opening pressure was 14. And so the neurology note comments that, obviously no concern for idiopathic intracranial hypertension. The ophthalmology note writes that there was suspicion for optic nerve drusen given her physical exam and a normal opening pressure on LP. But they didn't perform an ultrasound on the floor, and they basically said that they would perform the ultrasound in their clinic when she followed up in a week. But that was their, concern or their diagnosis. Neurology discharged her with Topamax for her migraines, and then she basically followed up with ophthalmology and neurology. So a little bit of a different, presentation, but ultimately had the same kind of diagnostic outcome. The interesting thing for her ocular ultrasound in the ER was that this little calcification there was not picked up. And so there was no communication to the team on admission that there was concern for optic nerve drusen on our ER ultrasound. And then, like I said, ophthalmology, did not grab our ultrasound machine in the ER. So, but she did follow up with ophthalmology and was confirmed to have neurology still for her headaches too. Right. So two different optic nerve drusen cases. If we don't have any questions, we'll go on. So this is case 4. This is a 14-year-old female who was healthy, who presented from an outside hospital for an eye injury. So she was playing outside with her brother and her cousins. Sounds like there was some BB action going on, and one of the BBs ricocheted off a treehouse and hit her in her right eye. She had eye pain immediately, eye swelling, but no vision changes. And so went to an outside hospital. They performed x-ray, and that showed a retained BB there near her eye. And so she was sent to our ER for further eval. So here's her exam when she got here. Was a little anxious, but overall doing well. You can see on the picture, she's got this tiny little laceration there to her medial lower lid. And certainly some bruising and some swelling there, but otherwise had full range of motion of her ocular muscles, and her pupil was intact, irregular shaped. So no concern for globe injury given her ocular exam. So here's her ocular ultrasound. Can you guys see that?
Got a foreign body sitting at 2 o'clock.
Yep, exactly. Yep. So you can kind of see that shadowing. That's really the giveaway here, right there on the edge. 2 o'clock is great. And this is a little bit better ultrasound picture there. So there's that BB that's retained. And so I thought this was a really great picture just because it really gives you the proximity for where the BB is in location to the globe itself. And I'll show you a picture of her CT here in a second, but you can really kind of get, how superficial that BB is. So it's not quite a centimeter down, but, definitely appears to be in the soft tissue. It does not appear to have any globe involvement as well. So ophthalmology was consulted, and they recommended a CT of her orbits. The CT showed this 5 millimeter metallic BB in her right lower eyelid, and it said closely abutting the globe. And here on this picture, you can clearly see that looks a little more dangerously close to her globe than the ocular ultrasound did. but there was no obvious intra-orbital injury that the CT saw. So I feel much more comfortable with this BB based on our ocular ultrasound than I would have if I had just seen the CT. So ophthalmology was at bedside, and they decided that they were going to try to, manually remove this BB. The patient got a little bit of Versed, and ophthalmology basically just extended that laceration and then was able to use manual manipulation as well as some forceps to grab the BB and get it removed, which was awesome for this patient. There was no other lacrimal injury, and she got a few little stitches there in her lid, and she was sent home. She got erythromycin ointment, and then she was followed up with ophthalmology. So pretty lucky that that BB did not go just centimeters further.
Did Opto see your ultrasound images?
Yes, they did. Ophthalmology is, I feel like an ultrasound savvy group. And so they're always interested in, look at our images. They do some scanning in their clinic, obviously. So I think, I think they appreciate it. Yeah, we did show them the pictures.
I just wonder with like your ultrasound and then just an exam, if they could have avoided having to CT the kid.
Yeah, no, I know. I think sometimes, when you consult them, they, kind of reflexively tell you like the plan and then say they'll come see them. So, I think that's unfortunately what happened was like, get this and then we'll be down. But yeah, I do think that the ultrasound helped more with the management of the patient. Maybe for low, injury, they wanted that CT. But I do think that helped with the bedside removal of the foreign body. All right. So now we'll go to case 5. This is a 15-year-old. Most of these are going to be like the adolescent population now. Who has ADHD, and she's presented with 1 month of headaches, had some intermittent blurry vision, and some intermittent vomiting as well. The start of this was about a month ago. She had a fever of 100.4, nothing higher. The fever had resolved, but the headaches and this intermittent blurry vision had continued on. She was seen in multiple places, so Immunity Cares, her pediatrician, and an outside ER. She had negative COVID, strep, and flu tests. She had several different lab draws, and they had all been reassuring, and then even gotten a CT head at the outside hospital, and all had been normal. Due to her discontinued intermittent blurry vision, though, she did follow up with ophthalmology, and at that office visit is where they found papilledema. They also noted that she had a right lateral gaze palsy and then a slight left vertical gaze palsy. And so they referred her to RER for further evaluation of those findings. So I don't have a picture of her eye exam. I wish we had taken one, but her vitals were all fine. She was pretty well. She was definitely not toxic appearing at all. Her pupils were reactive, but she definitely had that limited lateral gaze to that right eye. We felt like her left eye had pretty good range of motion, and it had some blurred optic disc bilaterally. Otherwise, cranial nerves, everything else was intact. Face was dimensional. So here's her ocular ultrasound, given her history of papilledema. We threw the probe on her. You can see the right eye and the left eye. Just kind of eyeballing it, there's, kind of something that sticks out to me. Just looking at it, concern for, mild elevation of those optic discs. And then, kind of eyeballing that optic nerve sheath. But otherwise, didn't see anything striking on this ultrasound.
I feel like there's some echogenicity in the nerve. I don't feel like I usually see, particularly on that right side.
You mean, oh yeah, right here?
Yeah.
Yeah. No, yeah, I agree. It does look a little strange there. A little bit different. So we got measurements there, and that right eye definitely had an enlarged optic nerve sheath diameter. Interestingly, the left eye was fine. And so we consulted neurology, given her palsies as well as papilledema, who recommended MRI as well as LP. Interestingly, on her MRI, she had this kind of small lesion on her right thalamus, which they kind of said was non-specific gliosis, or kind of this benign cameratosis lesion, but did not feel like that was related to her presenting symptoms at all. They also found idiopathic intracranial hypertension with some papilledema on her MRI. And so neurology that's what they felt like was going on with her. So she had an LP that next day with elevated opening pressures at 37. They did send some CSF studies. And the interesting thing for her was her white count was pretty elevated on her CSF studies. So 71 with a lymphocytic predominance. We did send a CSF pathogen panel, which was negative. So neurology consulted ID, given her palsy, her headache, and fever ×1, at the beginning of the course. And they sent some fungal studies on the CSF and on the serum, as well as Bartonella. Those obviously were not back, and she was discharged on day 2 with Diamox for her idiopathic intracranial hypertension. And so about a week later, ID gets the testing back, and she's got histo positive for her serum, as well as histoplasma positive in the CSF. And so neurology did diagnose her with histoplasmosis meningitis. And unfortunately for her, needs a pretty long course of treatment. So she got the PICC line placed, and she gets a month of amphotericin B. And she's currently getting a 12-month course of PO itraconazole for her histoplasmosis meningitis, which we actually see histoplasmosis pretty commonly here in Kentucky, from the Ohio River Valley. So it's pretty common. We'll see a lot of calcifications on chest X-ray from prior histoplasmosis, but pretty rarely do we see a histoplasmosis meningitis. So I thought that was kind of a neat twist to her ocular ultrasound. I feel like sometimes we just think just idiopathic intracranial hypertension and kind of move on. So she's doing well from looking at the notes and chart checking. I'm just curious, has anyone here diagnosed meningitis after ocular ultrasound or been concerned for it? Definitely something I'll think about a little bit more. All right. So case 6, this is a 10-year-old female. She's got a history of congenital CMV. She's got congenital cataracts, status post-extraction. She's also got epilepsy, autism, deafness, and she's blind in her left eye. And she presented with a 1-day history of just some right eye redness. So parents felt like this looked a little different, and they felt like maybe she wasn't seeing as well out of the eye. They felt like she was running into things a little bit more than normal. They felt like otherwise she was doing fine though, had no eye drainage, no eye, eye trauma, no fevers, no runny nose or anything like that. So just that 1 day of kind of redness of her eye. On exam, she was afebrile, pretty well appearing, very, very active 10-year-old. So exam was fairly difficult. She did have some marked corneal clouding in that left eye when she was blind, and then had some injection there on that right conjunctiva. Again, exam pretty limited due to her cooperation, but it was felt that there may not be much pupillary reactivity there. in our ultrasound. And both of these pictures are of her right eye, just 2 videos that I put in. Pretty impressive pictures. Anybody want to take a stab at it? So here you can see basically just this huge retinal tear and retinal detachment. This video is probably a little bit better to kind of see just complete tear. And then here's her left eye. And you can see, basically just very chronic changes, very, cystic left eye. It's kind of an interesting ocular ultrasound. And so I thought this was kind of a neat cartoon to basically show that retinal detachment. So you get this, tear there in the retina, and it just pulls away from those blood vessels, and you kind of get this, the fluid kind of goes in. You get this huge kind of mark or kind of towel across your screen where that tear occurs. And depending on where the retinal detachment is, depends on if it's completely across the eye or on one side. But pretty cool pictures when you see it. And so spoiler alert for her, when she came in, there was also concern for retinal detachment. The left eye had a retinal detachment 2 years ago, which is why it had led to her blindness in that eye. And that had just started with some eye redness from what the parents remember. And so, her right eye was her only functioning eye. And when she presented with redness of that eye, their parents were pretty astute and brought her in immediately, concerning for retinal detachment of that eye as well. So her case, ophthalmology obviously consulted, and she had to have a sedated eye exam due to her patient compliance. And actually the bedside ultrasound that I showed you, those pictures were performed while she was sedated. Otherwise, there's no way that they would have been as good as they were. So the ophthalmology note for this patient said basically multiple areas of acute retinal detachment on that right eye, and then basically kind of chronic cystic changes there in that left eye. So she was admitted and underwent surgery for her retinal detachment the following day. And looks like her chart checking had, good attachment and had some improved visual acuity on follow-up from the ophthalmologist. Just curious, has anybody seen any retinal detachments? It's not something that we commonly see.
I had one recently in a QA that was actually a kid visiting from Louisville for some reason. And
Was it this kid?
It was one that our fellow put in as normal, and it was a kid with similar like NICU chronic eye stuff.
Yeah,
It wasn't a great scan, but there was definitely something kind of flapping around in the breeze back there.
absolutely.
And we ended up having to like call him back and come back, and they did a sedated. They did like a bedside visit with opto, and then they basically discussed like sedated exam coordinated with the retinal specialist versus go back to your Louisville ophthalmology folks to see them, since you have so much history, and they wanted to go back. So I never got any closure on what they finally saw in their better stuff.
Interesting. Yeah, I feel like we have a lot of pathology here in Louisville, so I'm interested in crazy cases. But yeah, I know, this is, I think, the only one that we've seen, or at least had a scan in our QPath about. So, relatively rare, thankfully, in the pediatric population. All right. Well, this is my last case for the day. This is a 15-year-old female. She's on minocycline for acne, and she presented with 2 weeks of headache, some nausea and vomiting associated with that, and then some bilateral papilledema. So about 4 to 5 days prior to her being seen, she developed some blurry vision and then some left eye esotropia. And so she was seen at her local optometrist, and that's where they diagnosed her bilateral papilledema. And so they sent her here for further workup. She had no fever, no gait changes, or any other weakness anywhere. And she did not have a headache on presentation to RER. So here is her picture. So you can kind of clearly see that left eye esotropia there. Otherwise, vitals are fine. She had no fever. She was pretty well appearing. And that subconjunctival hemorrhage is due to the vomiting, associated with her nausea, vomiting, and headache that she was having. Otherwise, the euro exam was well, other than what we talked about. So, given her papilledema, we do the probe on her eye. Take a look. Here you can see the right and the left eye. And again, just a few things stick out to me just looking at it. Again, I can see that optic disc elevation, as well as her optic nerve sheath looks a little generous to me in both eyes. And so we got our measurements. Both the optic nerve sheath diameters were greater than 5, they were at 6. So, we were concerned with papilledema as well. Consulted neurology and ophthalmology. The patient was admitted. Brain MRI on this patient was normal. And then LP was performed the following day, again with pretty high opening pressures, greater than 56. And so the diagnosis was idiopathic intracranial hypertension. She was started on Diamox. And I couldn't get any, see in the notes if her palsy had resolved at discharge. So it doesn't, her discharge exam is normal. So I'm assuming that at some point during her hospital stay, her eye exam improved. And so I threw this case in last just because I wanted to kind of talk and have a discussion with you guys about, kind of what you're doing at your institutions with optic nerve sheath. So just a reminder that optic nerve sheath is just an extension of the dura mater, and basically has direct communication with the brain, which is why it's so great to measure to look for increased intracranial pressure. Certainly there's lots of literature out there on what it means to have, increased optic nerve sheath diameter, but, looks like about 5 millimeters seems to be generally our cutoff for, patients 4 and above. So I just threw out this meta-analysis. This was done in 2015. It included 12 studies and about 500 participants to look at optic nerve sheath diameter for increase in the cranial pressure, and it compared it to CT findings. It was 95% sensitive and 92% specific for increased intracranial pressure. So they concluded that was, pretty high sensitivity for ruling out ICP in a low risk group, and then high specificity for ruling in increased ICP for our high risk group. And so the next one is a little bit newer article in Critical Care of 2020. Again, not in pediatric patients, so adults. They were 120 participants, and they looked at not only optic nerve sheath diameter, but also started to throw out this optic disc elevation term. And that's why I included it here today. So I feel like that we're starting to look not only at the optic nerve sheath diameter, but also at that optic disc elevation. And so this paper used a cutoff of greater than 0.4 centimeter, 0.04 centimeters, and it was 90% sensitive and 71% specific. And the cool thing with this was the area under the curve for the optic disc elevation was 84. So not terrible for detecting pressures greater than 22. And so the conclusion with this was the measurement of the optic disc elevation is a promising tool to look for elevated intracranial pressure. Hot off the press, this was like a week or two ago. This came out from the American Journal of Emergency Medicine. This was a pediatric study, so kind of exciting, retrospective. It looked at 76 eyes in 40 patients, and they looked at optic nerve sheath diameter, optic disc elevation, and they kind of concluded the optic disc elevation for both eyes. So they did like a mean, generated the largest area under the curve at 0.96. And so their cutoff for optic disc elevation was 0.66 millimeters, and that had a sensitivity of 96% and specificity of 93%. So I just wanted to throw that out and get you guys' thoughts. I know, at least here in Louisville, I feel like we look for optic disc elevation. I can't say that I've started like measuring how high or how much it's elevated, but we do look at that as well as the optic nerve sheath diameter. So is anybody else measuring optic disc elevation, or what should y'all take at your institution?
When I look at both.
Okay.
I do a lot of looking just because we have MRI so easily available.
Yeah.
The lit, I feel like, on what are normals for especially sheath is sort of all over the place. I know the Tesaro group has got the normie study that they're still building collaboratives with and rolling, and we're going to be joining, hopefully, if I can get our IRB to not be obnoxious. But like my own optic nerve sheath is like 0.63 or something each time I've checked it. I'm like, oh, great, I've got a tumor.
Maybe you have an optic nerve trees in that. Yeah, I don't know. I feel like we're looking at it, but I haven't started measuring. So I'm gonna see what people are doing. Hopefully, like you said, we'll have some more pediatric literature out there, which I think will be huge for our patients. All right. Well, final thoughts that I had basically is just how quick and easy ocular ultrasound is to do. Obviously pretty accurate, generally pretty well tolerated with our patients. It's definitely very helpful when that fundoscopic exam is pretty limited. So I feel like, depending on compliance or the age of the patient, that can be pretty challenging, especially considering we generally don't dilate our kids' eyes down here. So I usually gravitate towards the ocular, ultrasound to look. We try to use Tegaderm, especially like in our younger, non-compliant patients, just to help us get a great picture and use a lot of gel. And then also to consider other causes of papilledema besides your typical IIH, which I feel like is kind of where I always go to. And then to think about ocular ultrasound if you're concerned for ocular masses or foreign bodies, definitely try to go there first. That can definitely help. These are my references. And that is all I have, guys. I'm sorry, I didn't see if there was like any chat, so.
Thank you, Rebecca. Sorry, I missed like 5 minutes just because my Zoom decided to not work. But thank you so much. Yeah, I missed the discussion where you guys the size of the optic nerve sheath diameter, because I was gonna say that I tend to use more on the 6 millimeter side.
Okay.
So I had some false positives with the 5 millimeter. When they're like 5.1, 5.2.
Right.
So that's what I've been doing so far. But then again, it's always kind of hard, especially after Aaron Chen gives a lecture, I think last year, like, sometimes identifying where the actual optic nerve is,
right.
Something that I'm still sort of like trying to work on.
Yeah, I know that's a good point. I think that's really hard to teach too, is like trying to find the axis of the eye and really getting, the optic nerve on axis. Just like you said, if you're off axis, it's going to be inaccurate numbers too. So I think that's definitely the one key, especially when we're teaching our fellows and our residents to really hone in on, is making sure we're getting the right axis.
Beck, I'm curious for you and anyone else, and this is sort of somewhat tangential. It sounded like most of the patients who got LP'd got done the following day.
Yeah.
Does like IR or do they do that with fluoro, or like who does that? If I take it the ED is not having to do it.
Yeah, no, thankfully a lot of especially for these where it's like papilledema and, that's kind of like the game plan. Neurology will sometimes do those the next day. Usually the patients have to get admitted for, some, imaging as well. So we typically don't have like a lot of MRI availability just due to like either the timing of the patient presenting. So they usually kind of end up getting admitted for other reasons too. And so they get the LP done with neurology the next day. We do some LPs for this down in the ER, but I would say I feel like a majority of our workflow is they do the LP upstairs.
That's interesting. Our neurologists send them to ED for their LP.
Yeah. Yeah, I mean, I think it's just a volume thing. I feel like our volumes have been picked up again. I guess with COVID, I can't really blame volume, but yeah, we're just so busy that it really is not like an emergent procedure that we need to do. So they'll get admitted and do it in the morning.
And then one last thought I had was I remember exchanging emails with Aaron Chen a couple of months ago. I knew you guys, there has been some papers in the neurologists, not done by PEMP doctors, who commented that the enlargement in the optic sheath diameter came bore the actual cupping of the disc, before papillary edema. They had like a small study sample, but they found that the optic nerve sheath diameter enlargement came before that. So if you see that, that would be diagnostic for pseudotumor. Something I was discussing with Aaron Chen, and he's never saw that. And unfortunately, in the paper where they described this, they didn't share images to see what they were looking at. But it's one of the only things I've seen where they're measuring just the optic nerve sheath diameter and making the diagnosis for pseudotumor. So I don't know if anyone else has read that paper or has even like seen that.
I don't think I haven't had a chance to read that paper, so I don't want to comment.
I mean, it's going to be non-specific, like the histoplasmosis case so nicely presented, which is kind of, oh my gosh, is that humbling? Holy cow.
Right, I know.
Yeah, for me, I stopped worrying so much about the decimal, 5.3 versus 6.3 versus whatever in the middle. It's part of the evaluation along with the fundoscopic exam. And most of these patients, I think in general, are getting an MRI to assess for other, causes of increased intracranial pressure before a lumbar puncture is done. So our workflow is kind of similar. It sort of depends on how busy we are. Plus minus, we do like an ultrasound assisted lumbar puncture in the ED, or they get admitted for, sedated MRI and fluoroscopy arranged sort of at the same time, depending on the age of the child, how anxious they are and things like that. So we don't have like a nice pathway for everybody, but it's nice to hear, sort of similar things are going on in other centers. So that's super cool.
I know, thankfully our volumes are definitely picked back up, so we have less availability to be doing the LP in the ER. But I agree. I think the use of ultrasound guided LP, I think as we start to delve more into that, then hopefully we'll be using that more, and we can get them done a little bit faster in the ER.
Rebecca, thank you again. Those are great images and great cases. So thank you so much. So.
Oh yeah, you're welcome. Thanks for having me, guys.
Yeah, and thanks everyone for joining. Rebecca, once again, thank you.
Yeah, you're welcome. Bye, guys.
Awesome job, Becca.
Thanks, Fred.
Good to see you, Becca. Hope things are well.
Yeah, you too, Matt. Thanks for your comments. Thanks for talking.